Hi, my name is Wenru Shieh. I am an infectious disease pathologist who retired from the US CDC last July. The title of this talk is Solving the Puzzle of Unexplained Outbreaks with a Multidisciplinary Approach. Although I used to be an infectious disease clinician in Taiwan before moving to the US, my professional training and certification in the US are pathology and laboratory medicine. So, my talk will be focusing on the laboratory aspect of the approach. There were many outbreaks occurring in the past 30 years, and many of them started without a known etiology. And the majority of these unknown outbreaks turn out to be emerging infections. Some of the well-known or infamous examples include the 1993 hantavirus outbreak in the US, enterovirus 71 or EV71 outbreak in Malaysia 1997 and Taiwan 1998, the Nipah virus outbreak in Malaysia 1999, and the West Nile outbreak in the US in 1999. The global SARS coronavirus epidemic in 2003, the H1N1 pandemic influenza outbreak in 2009, the Zika virus outbreak in South and Central America and several other regions in 2015, and of course, the still ongoing COVID-19 caused by SARS coronavirus 2 since early 2020. In 1992, Institute of Medicine, IOM, took the leading role to examine the impact of emerging and re-emerging infectious diseases in the United States. The Institute published a report entitled Emerging Infections, Microbial Threats to Health in the United States. The content of this report is also relevant to global health as well. The Forum of Emerging Infections was later created by IOM in response to a request from US CDC and NIH. The purpose of the forum is to provide structured opportunities for leaders from government, academic institute, and industry to meet and examine issues of shared concern regarding research, prevention, detection, and management of emerging or re-emerging infectious diseases. 10 years later, the impact of the global burden of infectious diseases has only increased, and several outbreaks caused by emerging pathogens have occurred. Therefore, a second report in 2003, which is the successor to the first one, was created and issued. The Institute of Medicine hosted a public workshop in December 2006 to outline the scientific and policy issues relevant to the presence of emerging infectious disease surveillance and detection. The workshop, right from the beginning, stated early detection is essential to the control of emerging, re-emerging, and novel infectious diseases, whether naturally occurring or intentionally introduced. Containing the spread of such diseases in a profoundly interconnected world requires active vigilance for signs of an outbreak, rapid recognition of its presence, and diagnosis of its microbial cause, in addition to strategies and resources for an appropriate and efficient response. So as we can see, some of the keywords here include early detection, rapid recognition, diagnosis of its microbial cause, and these are the essential and the most important points for any unknown outbreak investigation. There are many methods in terms of laboratory diagnosis of infectious diseases, which include the conventional culture, serology, and the more widely used molecular technology nowadays. And if tissue samples from biopsy or autopsy are available for examination, then many pathologic methods can help establish an even more precise diagnosis of infectious etiology. As I described in another talk, these pathologic methods include routine hematoxylin and eosin stain or H&E stain, which can help direct the subsequent ancillary testing through examination of the histopathologic features. Special stains such as tissuegram stain or GMS stain are usually more helpful for diagnosis of bacterial or fungal infections. Immunohistochemistry is a very useful method. By using specific polyclonal or monoclonal antibody, it can locate the presence of antigens in tissues. In situ hybridization is another useful diagnostic method. By using different probes, it can detect the nucleic acid in tissues and establish the diagnosis. Electron microscopy is the most direct visualization of microorganisms in tissues. And of course, a lot of labs are now using polymerase chain reaction or PCR assays, even on tissue samples, because the nucleic acids can be extracted from the tissues and apply these methods to establish a diagnosis. The 2003 global SARS epidemic serves as a prime example of using multiple laboratory methods for the identification and confirmation of the etiologic agent, that is, the SARS coronavirus. Like many other global outbreaks, including the current COVID-19, the 2003 SARS was an epidemic war with no geopolitical boundary. Although the fatality rate of SARS coronavirus infection is higher than the current COVID-19 caused by SARS coronavirus 2, fortunately, because of other nature of the virus, the outbreak was well under control within 6 months or so, and the countries involved in the outbreak were also not as many as the current COVID-19. From the table you can see here, China was the country with the highest number of cases and the number of deaths. Hong Kong number 2, Taiwan number 3, Canada, Singapore, and several other countries in the world. The total number during the SARS outbreak, according to WHO, was 8437 with 813 deaths. Any outbreak with a large global scale, even just a few months, can cause tremendous casualties, social turmoil, economic loss, and many other problems. Not to mention the current COVID-19, which has been ongoing for over a year. On February 21st, 2003, a Chinese physician from the Guangdong province who cared for patients with pneumonia and later developed symptoms himself traveled to Hong Kong to visit his relatives. He stayed on the 9th floor of Hotel M for a day. This hotel was later renamed Metro Park Hotel, and I had a chance to stay in this hotel when I went to Hong Kong to attend a meeting in 2005, and it has become a historic site because of the SARS outbreak. On February 22, 2003, Index Case A, the physician, was admitted to Hospital 2 in Hong Kong with fever and respiratory symptoms, and eventually died of respiratory failure on March 4th. He also spread the viral infection to many healthcare workers in Hong Kong. Index Case B, a businessman from USA who traveled to Hong Kong for a meeting, stayed in Hotel M, contracted the virus, and subsequently spread the viral infection to Hanoi, Vietnam, especially those people with close contact with him and many healthcare workers in Vietnam. 12 other hotel guests at Hotel M developed symptoms of SARS, 10 of whom, patient B through K, were in the hotel the same day as index case A. The other two patients, patients L and M, stayed in the hotel during the time that 3 other symptomatic patients were guests at the hotel. Because of the international travel and the transmission to healthcare workers before the institution of protective measures, these patients were responsible for subsequent cluster of SARS around the globe, including many other countries such as Canada, Ireland, USA, Germany, and Singapore. I'm going to describe a little bit more detail regarding index case B. As I mentioned previously, the patient was a businessman from USA who traveled to Hong Kong to attend a business meeting and subsequently flew to Hanoi, Vietnam for another meeting in February 2003. During his transition from Hong Kong to Vietnam, he started to have high fever and severe productive cough in the airplane and eventually developed respiratory failure, so he was taken to French hospital in Hanoi immediately after the airplane landed. At the emergency room, an anesthesiologist intubated him for emergency management of his medical condition. Unfortunately, the anesthesiologist and many other healthcare workers in the French hospital contracted the virus and started to show symptoms in the next 1 or 2 weeks. Because of the concurrent outbreak in Hong Kong, the Ministry of Health in Vietnam recognized there is an outbreak situation similar to Hong Kong, so WHO was notified and started to collaborate with the Ministry of Health as well as US CDC to start investigation. On February 28th, WHO assigned Dr. Carlos Urbani, an Italian epidemiologist, to Hanoi to start the investigation. Dr. Urbani described the clinical manifestations of the illness. Although no etiologic agent was identified at that time, he coined the term SARS, severe acute respiratory syndrome, to describe the illness. Later, the term was used to name the virus in memory of him because he contracted the infection and unfortunately passed away a few weeks later. On March 8th, Dr. Tim Ueki, an epidemiologist from US CDC influenza branch, flew to Hanoi to assist the investigation. Dr. Ueki was initially assigned to Hong Kong to assist the Hong Kong outbreak because there was a suspicion the Hong Kong outbreak may be the beginning of a pandemic influenza. I was dispatched to Hanoi, Vietnam several days later with 2 other CDC colleagues as well as Dr. Tim Ueki to join an international team formed by epidemiologists and other public health experts from different countries under WHO and the Vietnam Health Ministry's leadership. As a pathologist, my major mission is try to obtain tissue samples for testing if there is a chance to perform autopsy on fatal cases. Unfortunately, the previously described anesthesiologist who intubated index case B did contract the virus and eventually died of the infection. After obtaining the permission from the family and the superintendent of the hospital, I was able to perform a partial autopsy and get access to some respiratory tissues, including lung, trachea, liver, and spleen. US CDC and laboratories in many other countries started to test a variety of clinical samples, including bronchoalveolar lavage, biopsy tissue, or autopsy tissue from severe or fatal cases. Many of these were test negative for influenza virus, as I mentioned earlier. Initially, people suspect this outbreak may be the beginning of a pandemic influenza. After all the tests were negative, the basic microbiologic principle is to start with culture. Many clinical samples were submitted to special viral pathogen branch at CDC for cell culture and virus isolation. These clinical samples were handled in the biosafety level 4 laboratory because of their unknown nature. These samples were inoculated into a variety of cell lines, including viral cells, viral E6 cells, PK cell lines, and many others. Fortunately, some cell lines, including viral cells, especially viral E6 cells and PK cell lines, did start to show cytopathic effect after inoculation, which initiates subsequent testing. With the appearance of the cytopathic effect on the cell culture, the laboratory investigations started to see the light in the tunnel. Special viral pathogen branch applied convalescent serum from a patient on the cell culture, and by using immunofluorescence, positive signal was observed. This means whatever pathogen contained in the convalescent serum is relevant to the cytopathic effect on the cell culture. The next step is to send cell culture with CPE to our infectious diseases pathology branch by using electron microscopy with both negative stain method and thin section method. Viral particles were observed, and the morphology is indicative of a coronavirus. This is a surprising finding because never before coronavirus was implicated in severe or even fatal human cases. Coronavirus is a large family of viruses which can infect human beings and many different animal species. It used to be classified according to their antigenic properties into group 1, 2, 3, human coronavirus 229E and OC43, usually cause common cold in humans and were rarely associated with severe or fatal illness. So, when the EM finding showed the coronavirus morphology, it surprised many virologists and scientists because the findings seemed to be against the conventional knowledge about coronavirus at that time. However, the ultrastructure finding did provide a more specific direction for subsequent testing. The respiratory and enteric virus branch at CDC synthesized several degenerative primers based on the known coronavirus sequences and performed molecular testing, and the PCR assays showed a novel virus with sequence very different from all those conventional coronavirus at that time. To further confirm this novel coronavirus as the etiologic agent of SARS, it is very important to demonstrate the presence of the virus in lung tissues with related histopathologic changes. So, in several autopsy and biopsy samples, we observed the major histopathologic change as diffuse alveolar damage and almost 1/3 of the cases we can identify the presence of syncytial cells. By using several polyclonal and monoclonal antibodies, our pathology laboratory developed immunohistochemical assay and initially used cell culture as positive control. And this is Dr. Carlo Urbani's BAL sample that we prepare a paraffin-embedded block for immunohistochemical assay control. As you can see here, it's loaded with infected cells and a positive immunohistochemical signal for viral antigens. We then apply the immunohistochemical assay on lung tissue samples and demonstrated a lot of infected cells, especially in type 1 and type 2 pneumocytes with positive viral antigens. This illustrates the pneumocytes as the target cells for SARS coronavirus infection. The corresponding electron microscopy also shows a lot of viral particles in the lung tissue. By using double staining immunohistochemical assays with cytokeratin and surfactant, we further confirm the viral antigens in epithelial cells, especially type 2 pneumocytes. Later, we also developed specific probes for in situ hybridization and demonstrated similar localization of positive signals in alveolar pneumocytes and bronchiolar epithelial cells, further confirmed the presence of viral nucleic acids in these target cells. The stepwise approach with several different laboratory methods described above provided unequivocal evidence to support this novel coronavirus is associated with severe acute respiratory syndrome, in conjunction with similar reports from several other laboratories. The etiologic agent of this unknown outbreak was identified. After the identification of this novel SARS coronavirus, the classification of coronaviruses has been revised according to their genetic sequences instead of antigenic property. Now there are 4 groups of coronavirus: alpha, beta, gamma, and delta. Those cause more severe or fatal human infections are in group beta, including MERS coronavirus, SARS coronavirus or SARS coronavirus 1, and the SARS coronavirus 2, which is the etiologic agent for the current COVID-19 outbreak. In summary, I used the 2003 SARS outbreak investigation to illustrate the multidisciplinary approach for the identification of etiologic pathogen during an unknown outbreak investigation. These methods include cell culture and virus isolation, electron microscopy, PCR and phylogenetic analysis, histopathology, immunohistochemical assay, and in situ hybridization. These methods have been used in many other unknown outbreak investigations as well. This will conclude my talk. Thank you very much for your attention. Thanks to your society's kind invitation, today I would like to share with you some studies performed at US CDC regarding pathology and pathogenesis of COVID-19. The results of our studies have been published in 2 articles. The first one was published in Emerging Infectious Disease last September. It describes the histopathologic, immunohistochemical, and ultrastructural findings of fatal COVID-19 cases in the US. The second one was published recently in Journal of Infectious Disease. This article describes the findings in a series of autopsy cases by using the in situ hybridization and molecular methods. Both articles can be freely downloaded from the website. So today my presentation will be mainly based on these two articles. The COVID-19 pandemic is still ongoing. According to WHO's estimate, up to March 22, 2021, there have been more than 122 million confirmed cases and more than 2.7 confirmed deaths. When such an epidemic occurs, it usually causes a massive scale of global impact, including tremendous casualties, social turmoil, general public fear, psychological imbalance, economic loss, etc. I believe by now everyone is very familiar with the virus and the disease it causes, so there is no need to do basic introduction in detail. However, I think it would be beneficial to quickly review the coronavirus structure in order to understand its pathology and pathogenesis better. So there are several important structural proteins of coronavirus. First one is nucleocapsid protein or M protein. Its major function is bound to RNA genome to make up nucleocapsid. The second one, spike protein or S protein, which is the most important one in terms of immunopathogenesis. It is critical for binding of host cell receptors to facilitate entry of host cell. The third one is envelope protein or E protein. It interacts with membrane protein to form a viral envelope. And the membrane protein or M protein, which is the central organizer of coronavirus assembly, and it determines shape of viral envelope. Coronavirus is a large family of viruses which phylogenetically can be divided into 4 groups: alpha, beta, gamma, and the delta. Most of the human pathogens are included in group alpha or beta, especially the beta group, which includes those ones causing more severe or fatal human diseases such as MERS, SARS coronavirus 1, and the current SARS coronavirus 2. So now let's enter today's main theme. As we know, SARS coronavirus 2 mainly affects respiratory system. Infection of respiratory system is the most common cause among all human infections. Pneumonia or infection of the lung is one of the leading causes of death worldwide. It ranked number 6 in the US as the cause of death, and definitely will rank even higher during the COVID-19 outbreak. There is a large spectrum of diseases associated with respiratory infections. They can be caused by viruses, bacteria, fungi, or parasites. The infection can involve upper respiratory tract or lower respiratory tract, or both. The disease severity can range from asymptomatic, mild, to severe or even death, and the course can be either acute or chronic. It is essential to obtain a definitive etiologic diagnosis of respiratory infection for subsequent patient management and relevant public health measures. The most common types of clinical samples for laboratory testing include MP swab, nasopharyngeal swab, sputum, or tracheal aspirates. During the COVID-19 outbreak, MP swab certainly is the most common type of clinical samples for testing because it's easy to obtain. However, we have to keep in mind what happens in the nasopharynx or upper respiratory tract does not necessarily reflect the disease process in the lung or lower respiratory tract. The more invasive procedure, such as bronchoalveolar lavage (BAL), can obtain samples from lower respiratory tract and is better for a definitive diagnosis. And if the diagnosis can still not be made by these clinical samples, then lung biopsy, or if the patient unfortunately passed away, an autopsy tissue samples can offer a more precise etiologic diagnosis. There are different laboratory methods that can help us establish the diagnosis of infectious etiology. These methods include the conventional culture and serology and the more advanced molecular technology. All these methods have pros and cons, and we always have to interpret the results with their clinical correlation. If tissue samples are available from biopsy or autopsy, then we can apply a variety of pathologic methods to obtain an even more precise diagnosis of infectious etiology. The commonly used pathologic methods include the routine hematoxylin and eosin stain, or H&E stain, which can provide guidance for other ancillary testing through interpretation of histopathologic changes. Special stains such as tissue gram stain, GMS stain, or Watson-Storey silver stain are usually more helpful for diagnosis of bacterial or fungal infections. Immunohistochemistry is a good way to demonstrate the presence of antigens in tissue samples by using different polyclonal or monoclonal antibodies. In situ hybridization can locate the presence of nucleic acid of organisms in tissues and is another good way for infectious disease diagnosis. Electron microscopy is the most direct visualization of organisms in tissues, especially for viral infections. And of course, there are now many different kinds of polymerase chain reaction or PCR assays, which are very sensitive and can help locate the presence of nucleic acid in tissue samples. All of these methods have advantages and disadvantages, and in the CDC pathology laboratory, we usually combine these different methods and integrate the final results for the interpretation of diagnosis. Now let me illustrate the COVID-19 pathology from our studies. The major histopathologic finding of severe or fatal COVID-19 cases is diffuse alveolar damage, or DAD, at different phases. DAD is the histological hallmark for the ARDS, or acute respiratory syndrome. It is characterized by diffuse pulmonary endothelial injury leading to pulmonary edema from a marked increase in capillary permeability to water, solutes, and macromolecules. It is usually presented by an acute exudative phase the first week or so with edema and hyaline membranes and inflammation, followed by a proliferative phase and organizing phase, usually the second and third week, with alveolar septal fibrosis and type 2 pneumocyte hyperplasia. After the initial insult to the airway and alveoli, neutrophils and macrophages are recruited to the alveolar space, which can cause more damage through their nonspecific defense mechanisms. Since the epithelial lining is damaged, it allows plasma and proteins to leak into the airspace and cause lung edema. The edema contributes to the deposition of a hyaline membrane along the alveolar walls. The edema also interferes with surfactant, which is critical for reducing surface tension and allowing alveoli to remain open and allow air to flow in for gas exchange. If the patient survived the acute phase, the proliferative alveolar collagens will remain and result in fibrosis, which further limit the expansion of alveolar space for gas exchange. Now let's look at the pulmonary histopathology in fatal COVID-19 cases caused by SARS coronavirus 2 infection. One of the prominent findings is tracheitis characterized by moderate to severe mononuclear inflammation within the submucosa of trachea. This picture shows a higher magnification of extensive denudation of trachea epithelium, submucosal congestion, mild edema, and mononuclear inflammation. This picture shows exudative phase of diffuse alveolar damage characterized by abundant hyaline membranes lining alveolar spaces as indicated by the arrow. This picture shows proliferative phase of diffuse alveolar damage characterized by proliferation of type 2 pneumocytes as this cluster of cells indicated by the arrow. Rare atypical pneumocytes can be seen in some cases with enlarged and multiple nuclei and expanded cytoplasm. Bronchopneumonia with filling of alveolar spaces by neutrophils is a rather common finding, and these cases are usually associated with a secondary or coexisting bacterial infection. Other nonspecific pulmonary histopathologic findings in fatal COVID-19 cases include hemosiderin-laden macrophages and anthracosis, pulmonary microthrombosis in small vessels, and emphysema in patients with chronic obstructive pulmonary disease. Because most of the cases are older patients with underlying medical conditions or other chronic illness, it's not uncommon to see these nonspecific histopathologic changes in other organs, such as extensive glomerular sclerosis in patients with renal diseases, or steatosis in patients with diabetes or morbid obesity, or myocardial fibrosis and cardiomyocyte hypertrophy in patients with chronic heart diseases. Immunohistochemistry is an important ancillary testing for tissue diagnosis of infectious diseases. By using specific antibodies, we can demonstrate the presence of viral antigens in tracheal epithelial cells. This higher magnification shows immunostaining of ciliated cells. This picture, indicated by the red arrow, shows the desquamated type 1 pneumocyte in alveolar lumen. And by using double staining, we can demonstrate the coexistence of SARS coronavirus 2 viral antigens, the red color, with type 2 pneumocyte, stained by surfactant, the brown color antibody. This picture shows the colocalization of SARS coronavirus 2 viral antigen, the red color, with macrophages stained by CD163 antibody, the brown color, as the arrows show. The virus immunostaining with type 2 pneumocytes is also seen, shown by the arrowheads. This picture demonstrates extensive immunostaining of hyaline membranes in exudative DAD, and this one shows scattered immunostaining within macrophage in hyaline lymph node. By using in situ hybridization with the recently developed RNA-scope technology, we can demonstrate the presence of SARS coronavirus 2 nucleic acids in tissues. For example, this picture shows abundant staining by the engine in situ hybridization assay in hyaline membranes in the lung. This picture shows stippled ISH staining in hyaline membranes and strong staining in abundant intraalveolar cells, as well as clusters of macrophages. The significance of the in situ hybridization findings not only confirm the viral infection but also implicate the replication of virus in these cells. There are other rare findings by using in situ hybridization assay. This picture shows stippled ISH staining in the endothelium and the tunica media of a vessel in the cerebellar leptomeninges, while this one shows endothelial in situ hybridization staining within vessels in the kidney. These are relatively rare findings in all the fatal cases that we studied. As I mentioned earlier, electron microscopy provides the most direct visualization of microorganisms in tissues or cells. Although it's time-consuming and needs a lot of experience to interpret the findings, it is the most definitive way to show infection in tissues, especially for viral infection. This picture shows extracellular virion of coronavirus associated with ciliated cells of the upper airway. This picture shows membrane-bound vacuoles containing viral particles of coronavirus, and the arrowhead here indicate a vacuolar membrane. This picture demonstrates the presence of viral particles of coronavirus within a phagosome of an alveolar macrophage. The pathogenesis of COVID-19 is complicated, and there are still many questions without definitive answers. In the next few slides, I would like to speculate the pathogenetic mechanism of COVID-19, and certainly many studies need to be done in order to understand the pathogenesis better. Let's first quickly review the SARS-CoV-2 receptor and the cell entry mechanism. As we know, the spike proteins on the surface of the coronavirus binds to the angiotensin converting enzyme 2 or ACE2 receptors on the surface of the target cell. Another module which played an important role is the type 2 transmembrane protease serine or TMPRSS2, which binds to and cleaves ACE2 receptor. In the process, the spike protein is activated, and the cleaved ACE2 and activated spike protein facilitate the viral entry. The TMPRSS2 expression increases cellular uptake of the coronavirus. During certain inflammatory disorders such as pneumonia or sepsis, angiotensinogen are converted into angiotensin 1 by renin. Angiotensin converting enzyme or ACE further converts angiotensin 1 to angiotensin 2. Angiotensin 2 signaling leads to raised blood pressure or acute lung injury by promoting inflammation and fibrosis through the angiotensin 2 type 1 receptor or AT1 receptor, but has opposing effects through the angiotensin 2 type 2 receptor or AT2R. Angiotensin converting enzyme ACE2 converts angiotensin 2 to angiotensin 1-7 and angiotensin 1 to angiotensin 1-9 to a lesser degree. Both products, angiotensin 1-7 and angiotensin 1-9, signaling can attenuate the effects of inflammation and fibrosis through the MAS receptor, which promotes tissue regeneration. ACE2 has been identified as the receptor of both SARS coronavirus 1 and SARS coronavirus 2. And when SARS coronavirus 1 or 2 binds ACE2 receptor, the ACE2 on the cell surface will be downregulated. Downregulation of ACE2 promotes organ damage through the activation of the bad pathway, i.e. the ACE angiotensin 2 AT1R pathway, and deactivate the good pathway, i.e. the ACE2 angiotensin 1-7 and MASR pathway. Angiotensin 2 and ACE2 are critically involved in the disease progression, leading to hypertensive, ischemic, and diabetic cardiomyopathy, and to obesity-associated cardiac dysfunction. All these are risk factors of developing severe COVID-19 diseases. By converting angiotensin 2 to angiotensin 1-7, ACE2 shifts the balance to the cardioprotective ACE2 angiotensin 1-7 mass receptor axis as the previous slide showed. The renin angiotensin pathway is only a part of the COVID-19 pathogenesis. The disease outcome depends on the delicate balance of the responses along the pathway, and each response may only represent a small pixel of a much larger but still unknown picture. In summary, we can speculate the pathogenesis of COVID-19 is very likely composed of direct viral cytopathic effects and related host immune responses. As indicated by histopathologic and immunopathologic findings, the viral infection of respiratory epithelium and lung parenchyma destroys the protective barrier of respiratory system and causes diffuse alveolar damage. The corresponding immune responses may trigger cytokine storms, hypercoagulability, endothelial damage, and subsequent tissue damage in various organs such as heart and kidney. This will conclude my presentation. Thank you very much for your attention. Hope everybody will keep healthy and happy.